Professor Wu, thank you very much. And Professor Tila, Professor Yu. Today my topic is debate and research advances in rhythm control or atrial fibrillation. As we know, in the past 20 years, there's a big change for the rhythm control of atrial fibrillation. In the last 20 years, there are more and more research about atrial fibrillation, even more than acute myocardial infarction in the PubMed publication. In 20 years ago, the debate between atrial fibrillation's rhythm control has begun. At that time, the AFFIRM study confirmed the rhythm control is not better than the rate control for the mortality of atrial fibrillation. In the same journal, in 20 years ago, there's another study, is RACE. RACE study is for the persistent atrial fibrillation. For the persistent atrial fibrillation, the result of rhythm control is the same as for the paroxysmal atrial fibrillation. Rhythm control for the persistent atrial fibrillation didn't improve the prognosis of patients. And then 6 years later, the AF-CHF study proved for the atrial fibrillation with heart failure, rhythm control can improve prognosis of patients. So we got in the period of rhythm control for atrial fibrillation. We even forgot the rhythm control. So for majority of patients, we only give the patients the choice for rate control. But the rhythm control is more physiological. It should be better than rate control. But we didn't have enough evidence because we have no ideological methodology. After 20 years, in 2022, the study East AF94 published. This study included 2,800 cases for newly diagnosed atrial fibrillation. The rhythm control improves prognosis. After 5 years follow-up, the combined primary endpoint, including cardiovascular death, stroke, hospitalization due to heart failure or ACS, reduced significantly. The HR is 0.79. After the main paper published, the subgroup analysis also proved, we can see, for the heart failure, for the asymptomatic patients, rhythm control also can improve the prognosis. This is for heart failure. Why there's a big difference for the study to compare the rhythm control and rate control? We can see that 20 years ago AFFIRM, the patient is different. The patients are a little bit different from East AF94, but the majority of the patients have the same clinical manifestation. But in 20 years ago, we used too much amiodarone sotalol. But in 20 years later, we use more flucloxamine, genadrol. In 20 years ago, we have no use of ablation. Later, 20 years later, we have 19.4% of ablation for patients. 20 years ago, we used more decoction, but less beta blocks. And especially 20 years ago, the anticoagulation rate is only 70%. And also, that time we don't have NOAC. Today, 90% of patients have anticoagulation, and also majority of them use a NOAC. So it's a much better anticoagulation level. So totally, in 20 years ago, the stroke rate arrived 5 to 7% every year. But today, the average is 1.6 to 2%. But today, the two group, one is rhythm control, only have as low as 0.6% stroke rate. The control group is 0.9%, much lower than 20 years ago. So today's rhythm control established on a new strategy of complex management of atrial fibrillation with better antiarrhythmic drugs, better ablation, better anticoagulation. So together, the rhythm control today can improve prognosis. How to choose the cath ablation or antiarrhythmic drugs? That's the latest study, early AF study, including 300 cases. One group treated with cryo balloon ablation. Another group with antiarrhythmic drugs. Most used antiarrhythmic drugs is flecainamide. It's just like East AF94 study. So for the early AF study, the cryo balloon ablation have a much higher sinus rhythm control than the antiarrhythmic drugs. And also for a 3 years follow-up of early AF study, the rhythm control with ablation, cryo balloon, have a much lower progression to persistent atrial fibrillation. The paroxysmal atrial fibrillation get to persistent is a common clinical phenomenon, but a cath ablation is much better for the delay the progression of paroxysmal to persistent rate, much better than antiarrhythmic drugs. In the same time, another study is 200 cases of paroxysmal atrial fibrillation. One group is cryo balloon ablation, another group is antiarrhythmic drugs. The same result as the early AF study. The ablation have much lower recurrences of atrial fibrillation compared to antiarrhythmic drugs. In the delete, we have patients more and more belong to the early diagnosis. That means diagnosed within 1 year. How about after 1 year? The Australian New Zealand Clinical Trial Registry compare 100 cases of symptomatic atrial fibrillation. One group is diagnosed with 1 month. Another group is for 1 year. The two groups, one within 1 month or 1 year, there's no difference for the 1 year's prognosis. That means even longer than 1 year of diagnosis, rhythm control may have the same the efficacy and the prognosis compared to the very early intervention. This meta-analysis, catheter ablation for paroxysmal atrial fibrillation is much superior to anti-arrhythmic drugs as a first-line treatment. For how to consider the anti-arrhythmic drugs, this is a meta-analysis of 59 randomized clinical trials, including 20-30 cases. In the review of the meta-analysis, we can see the sotalol have a significantly higher mortality compared to the placebo. That means some anti-arrhythmic drugs may increase all-cause mortality. So we have to pay attention for sotalol. Even amiodarone have a trend to increase the all-cause mortality in atrial fibrillation patients. In more than 10 years ago, there's a very encouraging result of a thinner study. In this study, including 4,600 cases of non-persistent atrial fibrillation, the dronedarone improved prognosis significantly. But for the permanent atrial fibrillation in pilot study, the dronedarone increases the incidence of combined primary endpoints, including stroke, myocardial infarction, and cardiovascular disease mortality. So dronedarone can be used for permanent atrial fibrillation. For the heart failure, catheter AF study showed that catheter ablation improves the prognosis of heart failure combined with atrial fibrillation significantly. And for generally, in Cabana study, we have 2,200 cases that catheter ablation didn't improve the prognosis, but it decreased of cardiovascular death or hospitalization. Why there's a negative result for Cabana study? Because the number of patients that didn't arrive the design. That time, design is 3,600 cases, but because the study is too difficult, and the authors give up the initial design patient number. So the Cabana study didn't get a positive study. For the heart failure in Cabana study, 800 cases, the catheter ablation can improve the prognosis very significantly for the heart failure patients. ROFT-AF is also a study for heart failure with atrial fibrillation. For the catheter ablation can improve the quality of life. This study also finished early than design. Their primary design is 800 cases, but the study is too difficult. The authors finished the study early than design. They only finished the 400 cases. So there's a trend to improve the prognosis, but the number is not enough. So they only can get the conclusion catheter ablation improves the quality of life, not for the prognosis including death and and heart failure re-hospitalization. For the meta-analysis, there are 6 randomized trials. The cath ablation improves prognosis for heart failure combined with atrial fibrillation. So we can, we also change the strategy for cath ablation use in atrial fibrillation with heart failure. So in the guideline, we have recommend cath ablation as a class 1 indication for atrial fibrillation with heart failure. In future, we have to improve that cath ablation is more effective and can improve prognosis than anti-arrhythmic drugs. Now there are some clinical trial is ongoing. We hope we can have more reliable evidence to change the guideline. Thank you very much.